I bring my own cheering squad with me for self-esteem. Can we hear that? Can you hear me? I think so. Can you guys hear me?
He is a core ECMO specialist at the University of Iowa, and he is here to talk about principles of ECMO, philosophy and methodology, respiratory therapist role in ECLS patient management. So please welcome Ryan.
Thank you for that warm welcome. I said I bring my own cheering squad with me for self-esteem purposes. Came up with a really long, intelligent-sounding title, but basically what we're doing is going to go over what is ECMO and what is the respiratory therapist role in ECMO. Whoops. I did break it already. That's fine. We can use it there. I don't know why I'm hitting the wrong button. Yeah, I hit that one there. Yeah, let's try it again.
Okay, we're going to give him one more try.
All right, there we go. So some of our learning objectives here, we're going to go over some key concepts of ECMO, and we're going to describe the equipment. Hopefully we can get an understanding of the patient populations that we're going to use this therapy with. Go over some really boring science type stuff. We're going to go over some gas exchange physiology that you all learned a long time ago. We're going to look at the underlying principles necessary for the patient management once they get on ECMO. And then we're going to go over the fun stuff, the mechanical emergencies, medical emergencies. So first, maybe we need to define what we're talking about here. The term ECLS and ECMO are kind of interchanged and used together. ECLS is extracorporeal life support. Extracorporeal refers to outside of the body or medical procedures performed outside of the body. And ECLS can apply to just about anything, from VADS to dialysis, and in our case, what we're going to talk about is membrane oxygenation, so an artificial lung, a membrane oxygenator. Here's some patient or some center-specific data. ELSO is the organization that basically acquires all this data. We're an ELSO center at the University of Iowa, but there's hundreds of them all across the world, and they send in all of their specific case data to ELSO in Michigan, and then they put it all together in a database and they spit back some numbers, and we can look and see how we're doing, whether this is actually effective. And you can see we had 55 cases last year, which is our most ever, and we had some pretty solid outcomes. 100% of our NICU respiratory cases survived ECLS. And on down the line, PICU cardiac, 50%. That's slightly below the average. Anything that's in red there is below the average. Anything in green is above the national average. And then this is a comparison to international data. And this is basically since the start of the ECMO program at the University of Iowa, going all the way back to 1996. And so we've done a total of 363 patients, and about 229 of those survived ECMO, which is a 63% rate. So if you figure this is a patient population that when we put them on probably has a morbidity or mortality rate, of right around 90%, 80 to 90%. 63% survival isn't too bad. You're giving a patient population that's more than likely going to die at least a reasonable chance of survival. Once again, the numbers in green show where we're above the international average, and red shows where we're below. So this is a picture, just for comparison's sake, of the first ECMO survivor. This is 1971 in Burbank, California. Dr. Robert Bartlett, who's considered the godfather of ECMO, was performing cardiac surgery in California, and he and several other doctors wondered, okay, we're doing bypass in the OR. Why can't we take that same concept and apply it to bedside management of patients that are in severe cardiac failure or severe respiratory failure? This particular patient was a trauma patient in a car accident, I believe, and he was basically going to die, and they said, okay, let's give this a shot. So they put some tubes in him and would pump the blood out, run it through. This is the oxygenator. Things about the size of a tractor tire, as you can compare to what our oxygenators look like today. But he was on for, I believe, 7 days, and he survived a discharge. The condition he had that required this was what's known as shock lung, and many of you, if you work in an ICU, see this. Patient has a shock type condition, and you get fluid overload to the lungs, and you just can't ventilate them with a ventilator. Put them on the oxygenator, turn the vent settings way down, and see if they recover. So what does ECMO do? The goal is to improve tissue oxygen delivery, and we're going to talk about 3 concepts. It's oxygen content, oxygen delivery, and oxygen consumption. And those are the 3 things we're going to think about at all times when we're on ECMO. And then remove CO2. There are some cases where we put them on where their oxygenation's fine, like status asthmaticus, and we can remove CO2 from those patients without damaging the lungs. You allow for normal metabolism and then continue to let the lungs and or heart, because we can do this for the heart as well, to rest. And that's the key. This is not a therapy. It's not going to improve the organ at all. The organ has to heal on its own or be transferred to some other form of therapy. We're allowing the lungs and or the heart to rest so that they can possibly heal on their own. So here's the basic schematic of our circuit that we use. This is, many of you probably recognize this. This is our rotoflow pump. Pretty common. It was designed or developed for cardiopulmonary bypass in the OR, and then we have adapted it to use at the bedside. That's pretty much every ECMO application. All of it is designed for the OR. So most of these therapies are only approved for 6 hours of use, but then we use it off-label for days, weeks, months, in some cases years, to bridge this patient to either recovery, to another device, or to transplant. And what differentiates this pump unit from what we use is this oxygenator. This is the artificial lung. So we take the blood, put a tube in a patient, pump the blood out, run it through a pump, run it through this artificial lung, the oxygenator, which has gas, usually 100% oxygen, not always 100%, but some form of gas going in and coming out, and then the blood comes out the other side oxygenated, and the CO2 is removed or swept away by the gas, and then we return it to the patient. Many of you recognize this is our rotoflow unit. We utilize this on all of our neonates and small pediatric patients. What's not really indicated here, the blood usually coming from the patient is usually dark. Deoxygenated blood running through the pump goes into the oxygenator, and what comes out the backside is bright red, oxygenated blood. And this is the next generation. And you saw that gigantic oxygenator and just disgusting tubing setup from the setup in 1971. All of that is right here in one box. The red is the oxygenator, which is strapped to the back. The pump is actually on the back side of this console. All of your information right there is available right there in your controls. This unit can literally sit in the patient's bed, and we can transport them on ECMO without having to use another cart or anything like that. So define the 2 different types of ECMO that you will see. You'll see VA, veno-arterial, so we're taking it from a vein, returning it to an artery. And this will provide us pulmonary support as well as cardiac support. You get some cardiac output from it. And then veno-venous, so we're taking it from a vein and we're returning it to a vein. And this is used only for respiratory failure patients. There's no cardiac output or cardiac support provided. Comparing the 2, VA, it adds afterload because you're pumping blood back into an artery. The native cardiac output has to pump against that, so that does create a little bit of afterload. There's a risk of Air emboli, because you're pumping it into an artery, in some cases the kids into the carotid, so that's something to think about. In many cases, in the babies, we have to ligate the carotid because the vessel itself, after having that catheter indwelling, can't be repaired. And you can do central cannulation with this. Sometimes our patients will come back from cardiac surgery with the perfusion cannulas still open chest, and we'll just hook our ECMO pump up to that. It does not necessarily provide oxygenated blood to the lungs. It's something to consider. Since we're not oxygenating the blood directly to the right side of the heart, we're returning it back to the left side of the heart. Sometimes the lungs don't get the best oxygenated blood, and we'll discuss that a little bit later. But this is the only way we can provide cardiac support. So for your patients that are in cardiac failure, they're going to require VA. Your oxygenation is going to hover right around 100% for these patients, except in some circumstances. Always except. We'll go over that a little bit later. And your ideal venous oxygen saturations are going to be 65 to 75. On VV, a little bit different. You usually use a double lumen cannula. We usually put that in the right IJ. You remove and return blood to roughly the same area. You'll pull it from the IVC-SVC complex and return it to the right atrium. This allows for normal heart pulsatility. And VA can obscure the pulsatility of the heart, and in VV you don't have that. Your right-sided of the heart is oxygenated, therefore you can treat things like pulmonary hypertension because you oxygenate the blood that goes through the pulmonary circuit. There's no effect on preload or afterload, and you don't have to worry about microemboli because if you put little air bubbles into the right side that goes through the pulmonary vasculature, it de-airs it before it goes to the rest of the body. Your oxygenated blood is perfused to the lungs, and it's used only, well, primarily for respiratory support. You don't want to use this on a patient that is in cardiac failure. And we can keep our maintain our oxygen saturation, surprisingly, in the 70s or 80s. And we'll discuss why that is in a little bit. Pros and cons. VV is probably safer than VA. You're only putting one hole in a person instead of two. And as we said, you know, the risk for air emboli and things like that are less. The blood entering through your cerebral arteries, through the branches coming off the aorta, is many times more oxygenated, and we'll discuss that a little bit later. But there's a benefit to the brain perfusion and coronary perfusion with VV. The potential for ischemic injury to the lungs is decreased because, once again, you're oxygenating the pulmonary blood flow. And one of the disadvantages, it's not able to provide circulatory support. So if you're giving it to a patient that's maybe in cardiac compromise, you maybe want to consider VA. Here's a picture of typical VV cannulation. As you can see, this looks like two different tubes, but usually this is a double lumen cannula. In our adults, it's 31 French, so it's a gigantic garden hose. The tip rests in the inferior vena cava, and you draw your blood from the inferior vena cava and the superior vena cava. You pull your blood in, run it through the pump and the oxygenator, and then return it through a port that's in the side. We call it the jet, and it ejects directly into the right atrium. The key to remember with this is that it's not total bypass. So you're not going to provide 100% oxygenated blood to the entire body. It has to mix. And if you've got somebody that's in pulmonary compromise, their native blood is going to be horribly oxygenated. So you're going to get a mixing effect into the right side of the heart. But as we'll notate later, my favorite type of good is good enough. We're going to try to get their oxygen saturation up enough to where they're not in that shock or pulmonary compromise position. And here's another picture of it. The double lumen cannula we use is called an Avalon, and this is just a picture of it, what it would look like dwelling in the chest cavity there, drawing from here and returning to here. One of the things we got to consider with VV cannulation is recirculation. Sometimes the highly oxygenated blood that we return to the body is then pulled back into the draw circulation, and we want to avoid that. We want as much of that highly oxygenated blood to be given back to the body as we can. And so we have 4 factors that we consider for recirculation. Pump flow. Oops. If pump flow is too high, then you will cause that recirculation, the blood to be recirculated back into the system. Catheter position, if our jet is occluded somehow or not pointed the right direction, then that blood will be taken back up again. Native cardiac output, we need this patient's heart to function, and that's why it's not the best solution for patients in cardiac compromise. And then the right atrial size or intervascular volume. Many of you that have worked with ECMO in the past know that we tend to give a lot of volume, especially early on to these patients. They can get a little fluid overloaded. But the reason for that is without this intervascular volume, the pump itself will